Good morning, friends. This is a demonstration of Hydrozone and EBOO for FICAT grade 3 hip avascular necrosis. The complete procedure step by step is shown here. Ozone increases the vascularity of the avascular head, and a combination of ozone and hydrogen gases injected into the hip will produce gaseous arthrodiastasis. First of all, we take a 20 ml syringe and then we take a bivalve or a three-way. It is essential to connect the three-way connections in a right way and test that there are no leaks, because hydrogen is a very naughty gas, very light, lighter than air, escapes very fast. So, we have to ensure that the hydrogen stays sealed and there is no possibility of escape of hydrogen. So, we have locked the bivalve and seen that the air which we have pushed will not come out, the bivalve is sealed. This empty syringe is attached to a hydrogen generator and we wait till the hydrogen fills up into the syringe. Sometimes it takes pressure build up to produce hydrogen to fill the syringe. We take around 20 ml of hydrogen in the syringe and lock it. Next is collecting ozone. IAOS protocol now routinely advises 100 microgram per ml of ozone. After setting the appropriate switches, the machine is started with the appropriate flow, which in this case is 1/16th of a liter. The syringe slowly fills up because the speed is 1/16th of a liter, meaning in 16 minutes 1 liter of ozone will be generated. We need only 30 ml of ozone. However, we collect 50 ml and discard the first 30 ml. The syringe part is now attached to the bivalve. So 30 ml of ozone have been collected, connected to the bivalve. Now a third syringe is opened for mixing the cocktail. Only 2 ml of 2% lignocaine is taken. Hexadiluted lignocaine is the key. In a similar manner, only 0.5 ml of quinacort is taken, which is an extremely low volume. I do not do these cases in the theatre under C-arm because I think that I can get into the hip most of the times. The patient tells me that he feels the hip is expanding, and many a times I actually measured that the patient has gained some length after the procedure. This mixture is now diluted with at least 6 to 7 ml of saline, which makes it a hexadiluted solution. Both the syringes are handed over to the nurse with betadine. We expose the anterior portion of the hip. This is how I approach the hip anteriorly, and hip in this region is very easy to approach. If we are getting a give and tightening, we know that the needle is in the hip, the cocktail is injected, the hydrozone combination is now attached to the needle, and first we have to push hydrogen, which is a painless gas to cause diastasis. You can see I am exerting enough pressure, and then it is turned and ozone is introduced, the system is removed. Now we start the preparation for extracorporeal blood oxygen ozonization or EBOO. The most important piece of the equipment is the perfusion pump. This is not a laboratory perfusion pump, this is not a fish tank or an oil perfusion pump, this is a medical perfusion pump. We just check the speed and the duration and ensure the pump works well. A 500 ml bottle of normal saline is hung on a drip stand. We are diluting 3 to 4,000 international units of heparin into this saline bottle. I have a 5 ml vial of 5,000 units per ml. I have taken 3.5 ml, that is about 17,000 units, which is now pushed into the saline bottle from the top using a thick needle, and once the syringe is removed, that needle will act as an air vent. The saline is shaken to ensure that the heparin is distributed uniformly. And now the remaining 1 ml of heparin is mixed with 5 ml of saline to make sure that we have a priming syringe ready, which will be used for priming the recipient and donor sets after we approach and get the vein. So we can see that the syringes are ready, and now we are ready for the procedure. The special EBOO flask is taken out. It has got a stainless steel diffuser. The top portion has got 3 markings: a large circle, a small circle, and a plus mark. Through the large circle, we push a needle, and this needle will be attached to the ozone machine. So we have connected the ozone machine into the plus mark. We can remove the needle and see that the stainless steel diffuser shakes. So ozone tube goes into the plus mark. Next tube, again connected to a thick needle, I use 16G needles, is pushed into the small circle, and this goes to the waste, wherein the surplus oxidized material is coming down. A UVBI stand, an ultraviolet blood irradiation stand, is connected and hung to the drip system. The EBOO donor set is now open. Please remember, this video is being taken in real time, meaning the entire procedure has lasted only for 26 minutes. So, the tubings are uncoiled, examined, and the first step is to prime the tubings. The portion between the two red sections will be the one which is going into the perfusion pump. We uncoil the system. The spike end of the ozone part is pushed into the spike end of the heparin part is pushed into the heparin mix saline. Set is primed. Heparin flow is started, and this very diluted heparin is allowed to flow into the entire length of the tube. We must make sure that the heparin coats the interior of the tubes or primes the tubes so that we do not get any coagulation at a later stage. We can see that heparinized saline is flowing freely from both the donor and recipient ends. Once the set is primed, we attach the end of the heparin part to the system and the bottle is removed. The spike is pushed into the top of the bottle. Once the bottle is inserted into the hanger, all the hanging tubes are put over the top of the drip set to allow a free flow of ozone in and a free flow of waste out. The donor tube is now inserted into the perfusion pump. There are two red markings on the donor tube, and it is preferable or advisable that only this section is put into the tube, into the pump. The pump is switched on. We see the flow, we see a little bit of priming fluid flowing into the bottle, and once we are ready with the bottle, the recipient set is now open, pushed to the bottom of the bottle and connected or kept aside for connection to the recipient side at a later stage. You can see that the recipient set is being pushed from the bottom. As this is a gravity flow, there is absolutely no question of air entry during the return flow of blood, and thus there are no fiddlings with bivalves or air extractions or pumping in saline from the distal site, because all that has been taken care of by the proximal site from where blood is flowing uninterrupted and is immersed with its tip, with its volume being under the tip of the stainless steel diffuser, and ozone at the desired concentration of 85 to 100 gamma is being perfused. A Venflon has been located, Venflon has been inserted, and now we connect the EBOO tube to the vein of the patient, and we can see that as the pump runs, blood starts flowing from the patient's vein. Now, this is a very important step here, that the pump is unidirectional and the direction can be changed. We must change the direction to ensure that the blood is sucked from the patient and goes into the bottle. And even as it is sucked, it is being sucked with the apparel, and hence the apparentized non-coagulable blood goes into the pressure pump, raises up gradually and goes up to the top of the EBOO bottle. You can see the blood raising up, going slowly, and as the drops of the blood trickle into the bottle, we wait till the stainless steel diffuser tip is immersed in the solution before we start bubbling of the ozone, and once it starts bubbling, we can see the dramatic change in the color of the blood in the bottle, which is not purple like the venous blood that is coming from the patient, but suddenly becomes cherry red, clearly indicating that this blood is now and has been properly and fully ozonized due to the high concentrations and low volumes of ozone that are being administered to him in the current session. The patient is asked to squeeze a rubber ball so that the blood flows easily. The blood reaches into the bottle and ozone is bubbling through the bottle. We have to wait till at least 50% of the flask is full with blood before getting the recipient vein. Sometimes we get the recipient vein in advance and prime it with a heparin syringe. Here we have decided to take the recipient vein a little later because the patient's veins were all patent and doing good. So now once the tourniquet is tied, the vein is located and a Venflon is inserted. At IAOS, we teach to handle veins delicately and ensure that no thrombus forms. Use the thinnest cannula possible. So here we have used an 18G for recipient site, and once the bottle is more than 50% through, the set is primed, the air is removed, by opening the transfusion set, we can see that the return blood color is bright and tomato red, with a small air bubble which has been removed now. The recipient side is connected. Important point here is the donor and recipient speeds have to be matched. You can see the startling difference between the donor blood and recipient blood. The recipient blood is bright red. There are no filters used to filter the blood. There is no purification. There are no plastics in the system where the ozone is being sent. However, we can see that there is a dramatic difference in blood colors. At the gender specified time, which in this case was 32 minutes, we didn't run the video for the entire period. The donor connection is removed, and now we can increase the pump speed so that the blood moves rapidly through the system and empties rather quickly into the EBOO flask. We can see the blood rising up, emptying up, going through the pump, going up and quickly emptying. Once it is emptied, we remove the donor spike and also remove the heparin after switching off the pump and removing the tubings from the pump. All the donor tubings and connections are removed and the recipient blood is allowed to flow at its own speed while the ozone and waste tube connections are retained into the bottle. Now we have the glass EBOO flask, blood still in the flask, blood being continuously ozonated and a very little amount of heparinized saline has been used. The syringe almost has most of the heparin left, the bottle has most of the heparin left. So in this procedure we have used about 9,000 units of heparin, which is lesser than a single dose given post total knee or post total hip replacement. You can see that the pump is switched off. It is better to keep the pump speed at 10 at this stage because next patient we do not want to start at a very high speed. We can see the blood is cherry red and tomato red. We wait till the blood is completely drained and then we remove the set, allow the blood to drain out into the patient. This is the bottle and we can see how ozone has diffused directly into the bottle. No ozone protective masks have been used and there is no smell of ozone in the room despite using 85 to 100 microgram per ml of ozone for diffusion, which proves the Prakash-Prasham constant that up to 100 micrograms per ml, the entire ozone is absorbed by the blood. And this also says that for a 5 liter person, we need 500,000 to 600,000 microgram ozone. Medical therapists interested in learning this technique of how to use high dose ozone can please message me on the above number, and so far we have found extremely miraculous results with the procedure. Thank you.